Good evening, everyone. Welcome to this 132 episode of Gyan Pravah, the Fogsi podcast series, which is it's an innovative idea by our president, Dr. Sunita Tandulwadkar. So every day, so you can imagine we have already completed 131 episodes, and today we are on the 132 episode. And every episode till now has been it has been great learning for all of us, all the committee chairpersons. So Dr. Sunita has been a visionary leader of Foxy who started off in January this year, started with this year's theme, Ek Rashtra, Ek Mission, Swasth Nari, Samruddha Vadan, Har Ghar Foxian. That resonates deeply with our mission to empower women and enrich lives. Through all her impactful initiatives, which she has started, Know Your Numbers, the Sampurna Swasth Janma Abhiyan, Do Tike Zindagi Ke, the flagship Eagle project, Arogya Yog Yatra, Gyan Pravah. This is the podcast series, the Foxy Anubam, linking with all the Foxy, the presidents and secretaries of various societies, and the 7 publications, the Arogya Saki app. We are all weaving a strong and inclusive fabric that connects every Foxian to the heart of the association. So these efforts ensure that each member feels valued, involved, and an integral part of the shared mission. Some of the initiatives unique for cervical cancer, which she has started, are the Do Tike Zindagi Ke, which was launched on the World Cancer Day, the Foxy IMA project on training 50,000 IMA doctors on HPV vaccination, the Wave 2 educational program for Foxians on evolving science of HPV and newer techniques to handle myths to train 25,000 Foxians on HPV vaccination, the Swasth Nari Abhiyan Yatra, and the Mahakumbh on HPV vaccination, a vaccination series. So with all her unique projects, Madam is driving the nation, all the Foxians, towards an evolving, a changing scenario for women's health. So over to Madam for
Thank
her
you,
message.
Sarita. Thank you. Thank you so much. 132 episodes. Really, it's wow. And you imagine what we will be at the end in the December. We all will be enriched with so much of a knowledge, learning, experience. Nirja, actually, this podcast series I started only for the chairperson because they are the future leaders. They lead the Foxy. The first step is entry as a chairperson. They become vice president. Few of them will become Foxy president. And I felt giving them a platform to have an interview with whichever personality they like, maybe from academic, non academic, maybe from social, philosophical, spiritual, political, any background, and it will evolve them as a person. And what I realized is more than them, by joining every day at 8 p.m. and listening to all these podcast series, I feel I have been evolving myself. I have evolved a lot. I have learned a lot from every faculty they invited. They invited even from the central ministry like Mr. Nitin Gadkari. So there is a lot to learn from everyone. And I'm thankful to all the chairperson. Believe me, Nirja, I don't know, people say chairpersons work, don't work. I found they work immensely, non-stop. Sarita, I was not much aware about her before, but I observed her in with her work. She's very meticulous, very disciplined. The way she compile the report, the way she present the report, it's just amazing. And Sarita, this quality of yours, along with your honesty, hard working, dedication, will definitely take you to higher position, not only in Foxy, any organization you wish to join. So I am
Thank
always
you.
cherished. We have given 300 CMEs to them. My job is to collect the money, companies, everything. I don't want my chairperson to run behind the companies. It's my job. They have to just perform. And believe me, on this weekend, we had only on Saturday 6 Sampurna CME across the country and a presidential conference happening in Bangalore. And I just saw Sureka Taide and Rohan has added two more CMEs and the programs on the weekend. So you just imagine 10 societies were doing Foxy programs over the weekend. That's fantabulous. And this is possible only because of my committee chairperson. They are the pillar of strength. Everyone is working nonstop, whatever they have been given. And the way Sarita is working in our all oncology program. And Sarita, always feel free to talk to me, but believe me, you are amazing. Start
Thank
believing
you.
on you that you are amazing. Have a power in your hand. And today you got another powerful lady of Foxy. Let me call her as a Foxy lady only because I know she has a capacity to lead our organization the year she decides. And above all, she made all of us proud. See, getting a Padma Shri for herself, fantastic. That's a feather in her cap, very big feather. It may be a beautiful feather for the organization in which she is working in her profession, the institute. But for a Foxy, our gynecologist, our leader, getting some uh, mm, honor is always proud moment, and getting Padma Shri is super proud. Nirja, you given the Foxy the platform to feel nationally recognized. And I'm thankful for that. And that's because of your dedication and hard work for years together on particular field. I think cervical cancer is your probably the year you will decide to become a Foxy, it will really become a Bharat Mukta, cervical cancer Mukta Bharat. I'm very sure when we all work. And I think this year, my Foxy program, we have also launched Nirmal Banaras Abhiyan, which is also one way. We have taken one city, that is Banaras, Varanasi, not only because it is PM Modi's constituency, but also we have a Tata sub-center. So those who are HPV positive, they will be automatically taken care of by in Tata. So we tied up, and 20 private. It is not in a public sector. We have done it with the private sector, 20 nursing homes from gynecologist. Our Foxy members joined. Ritu Khanna is helping there along with Bhagyashri and so many team members. So, Sarita, please, I know you are working very hard for all the cancer project, but you can come out with your innovative idea and we are here to roll on. Thank you, Nirja, for coming on this platform, making Gyan Pravah another highlight program by your presence. Thank you. And I wish both of you the best dialogue. Our protocol is I log out after your introduction, Nirja, and I go from the viewers link. So the two beautiful ladies having their dialogue will be the only picture people will see. Thank you.
Thank you.
Thank you,
Thank you,
Dr. Sunita,
madam.
for your wonderful words. I think it's an amazing initiative you've had. All your initiatives are very good. It's hard to tell which one is the best, but this is certainly the most different one as far as Foxy Projects goes. So I really congratulate you and thank you, Dr. Sarita, for inviting me here today.
Thank you, madam. Thank you. So you all, I know, I'm sure all of you know Dr. Nija Batla. She has been the professor and head of the Department of Obs and Gynae at All India Institute of Medical Sciences, Delhi, the WHO Collaborating Center for Cervical Cancer Prevention and Research at AIMS. She has been the past chairperson of the FIGO Committee for Gynae Oncology from 2015 to 18, the past Secretary General of the International Federation of Cervical Pathology and Colposcopy, and the past president of AOGEN. She has had a professional experience of over 40 years and has conducted trials on various aspects of cervical cancer prevention with special reference to low resource settings.
Suddenly on one day.
Yes, ma'am? Including
Please
HPV.
continue.
Yeah. HPV epidemiology, HPV vaccination, screening, and treatment. She is consultant to the WHO, International Agency for Research on Cancer, and a member of the technical group for WHO's Cervical Cancer Elimination Initiative. She has published over 300 papers and with a H index of 47 and is among the Stanford's top 2% of scientists since 2020. In 2021, she was awarded the Shobha S. Wenger Distinguished Chair of Gynae Oncology at AIMS, New Delhi, and the FRCOG, the at UDEN from UK. She was the recipient of the WHO IARC Award for Women in Cancer Research in 2023, and recently she was awarded the Padma Shri by the President of India, which happened a few days ago. So welcome, Dr. Nija, for this Foxy podcast on the Gyan Pravah, the 132 episode.
Thank you, dear. Thank you so much. Once again, thank you to Dr. Sunita and to you for this kind honor of being one of your esteemed dignitaries on this wonderful series.
Thank you, madam. Thank you. So let us begin with the dialogue, Dr. Nija. So these, you have been in the gynae oncology, the gynae cancers. You have been leading all the work for cervical cancer. How did you actually get interested in gynae oncology and cervical cancer prevention?
That's an interesting question, actually, because, for some reason, I don't know why, it's not that there was cancer in my family or friends or anything, but right from the time I joined as a junior resident in the department, my interest was cancer. My teacher, Professor Bhargav, said, "What would you like to do your thesis on?" I said, "Anything with cancer." And at that time, circulating immune complexes pre-CA 1 to 5 times, we were looking for biomarker. Dr. Pradeep Seth was my co-guide. He made me sit in the lab and do the test myself. I think it gave me great insights into combining clinical and lab work right from then on. But you know what? Even globally, if you see, not just in LMICs like Dr. Shankar, Dr. Lynn Denny, not in WHO only like Dr. Partha Basu, but globally, there has been gynae oncologists who have led the research for preventive oncology. Dr. Walter Kinney, Dr. Henry Kitchener, Dr. Walter also. They've all been gynae oncologists who found it important, because when you see the effort you put into treating a cancer patient, and not always with the best results. I remember those patients who we did pelvic exentration and who could barely live. We remember those patients whose children suffered when they died, educated patients not getting screened adequately and coming. It was really heartbreaking and frustrating. And one felt that for a cancer like cervical cancer, which is so eminently preventable, the West had shown us the way for decades. Why cannot we do something about it? And that was why cervical cancer is sort of the most obvious first one, because it has a high burden. It has a long pre-invasive phase, which is amenable to screening, which is amenable to treatment. You can prevent the cancer. It's not just early detection, but actual prevention. And so it seemed that there has to be a way. We cannot be so, sort of constrained that we cannot offer this to our women.
Yeah, absolutely. This is one cancer where really prevention is possible. So when did you actually start working on the HPV vaccine?
So the HPV vaccine actually came much later. The first studies we did were on screening. And we were, of course, going out into the community, motivating the pathologists to give us some cytology bottles for doing camps out there in our urban slum areas, in our village areas. But it was actually the first one that I really got into in a big study format was with Johns Hopkins, Bloomberg University, with Dr. Kirti Shah's group, where we started, and with Dr. Shankar doing trials out in our villages near Ballabgarh, doing trials on screening with the pap smear, comparing it to VIA as our low resource setting test, and then also with HPV. But HPV those days was a very expensive test. And it was like we could see the results. We could see how good it was, how much better it was. And we were like, how can we ever afford this? It's so good, but how will we afford this? And then there were the low cost tests which started coming. which were which were incentivized by Gates Foundation, and we had the CARE HPV to start with, and now we have our own Indian tests which we have recently studied. But still, there is a gap to be filled in that. But this HPV, Harold Zurhausen making that discovery, which led to him getting a Nobel Prize in 2008, but it was since the 80s that he had been working on it, which showed that HPV is the necessary cause that led to the development of HPV vaccines, because it's very few cancers that have an infectious cause. So that led to the development of the vaccines. The first licensed vaccines came in 2006. And we worked with them since 2009 because they needed the licensure in India. They needed the Indian studies. So we had the multi-center studies. We actually could use them ourselves and see that they were safe, that they were well tolerated, they were highly immunogenic and effective. So we had them coming into the country from 2009, 2010. And then was the IARC trial that we started at that time, which was on fewer doses, which started as a 2-dose versus 3-dose, and which for us, after a series of events, landed up at looking also as single dose, which very serendipitously, I think, has been one of the greatest contributions, not just to India and LMICs, but to the world, to have a single dose of a vaccine, which no immunologist believed can work with fewer doses.
Yes, that is really wonderful. I think the change that the evidence that India has shown to the rest of the world. Yes, absolutely. So that will be really useful for the whole world and for our country as well.
Yeah.
So
Gavi had a price of $5 a dose. It started at $120 a dose, inconceivable for a country like ours. But Gavi had a price of $5 a dose. Even that was more than the price of all the other childhood vaccines put together. So it was not really good enough to think of that as an alternative. We had to have our own cheaper, affordable option. That was the only solution that we could see in the field of vaccination.
And hopefully we will have the Indian vaccine also, which will be a reduced dose. Hopefully we will have some evidence soon, and we can actually be looking at us at 1 dose and reduced doses actually. So that will be really a game changer, and that will help in getting the vaccinations to all our girls. So Dr. Nisha, how has, coming to the screening, how has the cervical screening landscape changed in the past few decades?
I will say it has changed and it hasn't changed. What has changed is that we have a lot of information on a plethora of options. We have the cytology, which was always available, but we have the BIA for the low resource situation. And by low resource situation doesn't necessarily mean hamlets and villages. It also means situations like medical colleges, which have limited resources for doing cytology. It can be anywhere at any level. And most importantly, it has the HPV test. And the HPV test has not only a very high sensitivity, it has also a very high negative predictive value, which means to say that if you do a test and it is negative, roughly we have seen when we go into any unscreened community, whichever test we use, we have about roughly a 6 to 7% positivity. But what is different is the ones it picks up and the ones it misses. Because with HPV, you're least likely to miss out those women who are actually going to go on to develop a CIN. And that is where its power lies. And that is the reason why WHO now in the elimination target says that if you can just do it twice in a lifetime, that is good enough. Dr. Shankar's study, which was the famous landmark NEJM trial, was like 1 round of HPV testing. And now, even that, I think if we get into motion, we are going to get some headway. But WHO definitely endorses 2 rounds of HPV. But here I want to add, Sarita, that all HPV tests are not the same. And unfortunately, we see a lot of people just doing homegrown PCRs. And we have seen how important it is to do the validated test, because the quality of the primers, the quality of the chemicals being used, everything can impact. So on the one hand, PCR can be extraordinarily sensitive, picking up a few copies that are not going to be of clinical relevance. And on the other hand, we have seen PCR missing out disease because it did not have the right primer mix. So it is very important, if we are to use only HPV testing, it's very important that we have to use a validated test. But when I said that I don't see too much change, it's like the coverage is not where it should be. The awareness is better, but the acceptance of actually getting testing done the way it should be done. So that is something where awareness about cervical cancer has improved. But the awareness, the acceptance of the need to go get the test done, even in urban settings, needs to be better.
Yeah. But coming to what do you think about the gynecologists? Do you think they're adapting to HPV, or are they want to go with the pap test? So what do you think is
Firstly,
the
there's nothing wrong with going with a pap test if you have
Hmm.
good quality assured labs. The most important thing, the problem with pap is that it is an inherently lacking in sensitive test. There's nothing anybody can do about it. Yet, in very good labs, in very good settings, you can find a sensitivity going up to around 70, 75%. So, if you have a good system and you're going to do it every 3 years, as is the recommendation, you're fine to stay with the PAP also. But now, as I said, a good HPV validated test used instead of not just a co-test. Co-test is not required if it's a validated test, can change it. And you might think that it looks more expensive than a PAP. But when you look at the number of times you seriously need to do the PAP versus 2 times of HPV testing, I think the costs are actually much better with the HPV test than they are with cytology.
Right. So what about the homegrown HPV tests? So do you think that they can be applied for mass screening?
So the Indian tests are actually quite well validated now. Some of them definitely look like they meet the international criteria, which are quite stringent, and they can definitely be applied for mass screening. And I think the next step is that we have to have some implementation projects to show that these can be used in various settings, and and they can be scaled up in production, and they can be used in our national programs, hopefully.
Right. So that will be really good, I think, for our country. So, Dr. Nija, what do you consider, as you've worked on so many projects, but what do you consider as your significant achievements?
So, I think I was very fortunate in the first place that I found really good mentors. I found very good mentors and very good role models who showed the way. As I said, it was kind of a little bit obsessive on my part. I really wanted to do something about the cervical cancer prevention. And one thing led to another, and we were able to do many projects with different aspects of screening, looking at the various tests, of course, but then looking at options like self sampling, looking at the screen and treat option, looking at screening in HIV populations, which are really most disadvantaged of all the communities we see, is the group which has the HIV infection and much higher risks of cervical cancer. And so various aspects, screening in pregnancy, so many things we looked at, and we were actually able to assess for ourselves on the ground the problems and challenges in each of these settings, how they are, and what can possibly be solutions for that. But I think screening has a lot of problems because it's not just screening. Every woman who has a test positive is not going to develop the cancer. The first thing is for them to understand that and not go rushing to get a hysterectomy done, which has been sometimes the case. But the other thing is how to do that triage, how to link them to treatment, how to transfer people from the primary setting to the secondary. I have seen situations in villages where women from one section of the village won't go to the other section of the village. And in the same small village, we've had to set up multiple screening settings. So we have to see how to minimize the referral, because you can't be telling everybody to go when only a few of them really need to. So how to do that triage, whether by VIA, whether by an HPV test that has a built-in genotyping, whatever may be the method we choose, and then to shift. Now, what happens when they get shifted to a secondary level or a tertiary level is the burden of curative care is already so much on the physicians that unfortunately preventive takes a backseat. And you can't expect women who are not actually suffering much trouble. You've screened them and told them that they have a problem which they didn't think they had in the first place. And now you're telling them come back another day and get treated. No, that can't, you can't expect compliance. So there has to be a way that we find channels and do all that. So when you look at all the problems that are inherent to the screening pathway, definitely vaccination is the strategy which is eventually going to be the winning solution, because that's something which is well understood in this country. It's well accepted and trusted. And when rolled out in government platforms, even the private sector takes them on more forcefully. So I have great hope that once we start with this in our national program, and we've seen in COVID how our systems perform so well. We have last mile facility linkages. We have people who can go, whether you have seen them in COVID, going on camels across deserts, going in boats to the remotest islands. We can actually very rapidly ramp up coverage there. And of course, these girls, it will be some time before they show. So we can't let go of screening. But eventually, in the long term, it is this vaccination which is going to be the boon for the women of this country.
Yeah. So, what challenges during these journeys that you have you faced?
So challenges in respect of the research that we did were the usual ones about finding the funding, finding the sponsorship, finding your mentors, finding the right group of people to work with, and all of which I was really, really fortunate, and I have always found support. And I will say this to everybody who wants to work on any projects. If you have the right cause, the money comes, the funding comes. You just have to see if it was refused, why it was refused, and you end up with a stronger project. But the main challenges lie in the implementation, in getting our own community of doctors to speak with one voice. For some reason, there are, even within our medical community, there are naysayers. And I'm not sure why they get these feelings of vaccine hesitancy, for example, or not trusting certain systems for another. Because really, when you work with the vaccines yourself, you see how safe they are, how well tolerated they are. And you look at the data coming from countries who have taken the lead in implementation, whether it is Australia or UK or Sweden or Finland or any of these countries, you see the data they are putting out already. We thought there's a very long lag time of 10, 15 years before it becomes a CIN, and even longer to go to cancer maybe sometimes. But it's amazing how fast we are seeing the drop in systematically studied communities, that the girls who have received the vaccine by the age of 13, 14 are showing incredible protection against this virus. And so it's cervical cancer is one of the things you're protected against. We are most concerned about it because of its large problem, the attributable fraction, almost 100% caused by this virus. But there are many other things, many other cancers in girls and in boys, which can be prevented by this one vaccine. So it's against all of HPV disease caused by 16, 18, and whichever other types we may include in the vaccine. So it is something which I wish that we are past that now, and that people have understood that it's extremely safe. It's not going to do any harm to the reproductive system of the girls. It's not going to cause any other side effects more than are seen in the general population, and that they will wholeheartedly accept the vaccine and have the benefit of this strategy.
Yeah. I think definitely there has been a change in the acceptance. People are accepting it much more than they used to a few years ago. But still, there are, still there is a section which don't believe in the vaccine. So there are anti-vaxxers. So I think that really needs to be probably with the when the government introduces it, so that this problem will be sorted out. They will be less in numbers. So, Dr. Nija, you have done, been involved in so much of research. So, what do you think about the status of research in India?
Somebody once said that it's not sufficient to be using evidence-based medicine. You should be generating it yourself too. And I think that's a very loaded and very correct statement, because where does evidence come from? It comes from our experiences. And there's a very well celebrated author, Dr. Atul Gawande, who writes beautiful books about his experiences of medicine. And in fact, at one time, I even gave away copies of his books, Better and Complications, etc., to my residents, because I felt it echoed a lot of what I believe and tell them. I said, maybe you'll believe it better when you read it in a book. And I think the one thing that really hit me there was, we say we're very busy as obstetrician gynecologists, so we really believe and we really truly are busier than many other specialties. So he described how during the Iraq War, they meticulously made notes of every case that came to them, no matter how busy and short staffed they were. And it was studying those notes that eventually led to forming, SOPs on which patient needs to be immediately transported, even though he's not looking so critical right now, versus the one who can be treated in the field hospital successfully and led to much less of casualties. So it's about discipline. It's about what we think that we can have time for. Whatever is compulsory by the law, we will do it. So can we make a law for ourselves that we must make a systematic analysis and write down every little bit that we do? And I will hear, in fact, I remember Dr. Kriplani who would tell me that, Nirja, you should start some projects in your colposcopy clinic and systematic data analysis. Honestly, she was one of the people who had given more importance to that than anybody I know. And truly, it's when you sit down and systematically and analyze your data that you see what it's talking to you, and the power of honest data to tell you something and your openness to receive that message. And I think there are two types. There's one, it's every practitioner sitting in their clinic can definitely compile their data. And we have so many forums now, so many Fogsi conferences where people can present. And I will say even senior consultants should not hesitate to present their data and free communications, which is what we see in international conferences everywhere, because that has a certain merit more than trials. Trials have their own advantage, but hearing about personal experience has its own. And for trials, we should think big. We should not be constrained by numbers. We end up with most thesis, of course, but even otherwise, sometimes saying larger studies are required. So who's going to do those larger studies? So let's plan big, get people together, make consortiums, have multi-center to get our numbers together very rapidly and show the world the power of our data. When I was doing the last cervical cancer staging revision in FIGO, there were many people from India who would write to me saying, I feel it should be this and I feel it should be that. It's not about feeling, it's about publishing your data and having it there. So the next time somebody does a staging, they pick up your data and they see and they use that data. So I will say that everyone at their own level should be getting their data together, asking questions which bother them, finding answers, presenting, publishing, being open to criticism, being open to review. I think that's how you grow. And it's so enjoyable. Once you start doing it, you just get a real intellectual satisfaction as well as the joy of sharing your information with everyone.
Right. And how do you think, follow-up can be organized? Because we that is a major problem that we face with our population.
I think Foxians have a very, very important role to play. Many of the government programs related to maternal mortality, related to emergency cesareans, and so many things Foxians create. Foxians have been the one who have really strengthened the hands of the government, and the government, for the same reason, really takes Foxy very, very seriously. And I think this is something which Foxians can definitely organize themselves well. And under your leadership in the oncology committee, I think there can be a way that we can work with strengthening the national program, with helping with their thing, maybe having a day which can be for cancer follow-up services, just as we have an ANC day. We can ask Foxians maybe to commit a day when they will do cervical cancer, and I will say equally breast cancer, because breast cancer being the number one, and the women really prefer to come to the gynecologist for this. So a screening for breast and cervical cancer day, if Foxians can help to support, I think it will go a very long way.
Right. Yes, definitely. So, Dr. Nirja, the cancer registry reports suggest a decrease in cervical cancer numbers over the years. In fact, yesterday I was in Calicut, and they say that cervical cancer numbers in Kerala, the incidence is just like 6.5 per 1 lakh women, and probably they will be the first to be eliminating cervical cancer. So, what do you think this means for our national strategy?
Yes, indeed. There is such a wide variation in cervical cancer incidences. Wonderful data coming out from the National Cancer Registry program. And we look at all the registries, we see that it varies from, as you said, as low as even 5 and 6 to as much as 27 in registries in the north.
Yes.
That's an alarming difference. One problem we do have is that cancer is not a notifiable disease, and to the extent to which we get the reporting depends a lot on the effort that is put in by the local registries. But of course, an indicator, and the trends are more important than the actual numbers, I think, because the actual numbers are sometimes an estimation and an approximation. So definitely we should make it a notifiable disease, and some states are taking steps towards that. And the declining trend, there have been many theories about why it is declining. That's good and that's true. And even when we sit in clinics, we don't see them walking in now the way they used to. You could smell the patient coming in because she had a urinary fistula. You could know that she's coming in with cervical cancer because of the terrible odor of a necrotic tumor that she was harboring. And you don't really see them so much anymore. Women are not so hesitant to tell also. Sometimes they would come only when the daughter-in-law noticed that there's a blood stain on the mother-in-law's sari. Now they're a little bit more open, I think, and that's one change that we have seen. So definitely it is declining. We don't see them as much anymore in the clinics also with the advanced stages as we used to. But the question is that how we rely on it, and why is the decline? Because our screening has not reached that level. 70% is what was shown by Michael Quinn, that when screening coverage happens is when you really see the decline. And we are nowhere near that. So is it our sporadic efforts that have contributed, or something more? And possibly the change in epidemiology has also contributed. The raising of the age at marriage, the fewer number of children, the better attention, your STI treatments by syndromic approach, the menstrual hygiene, all these things have also possibly contributed to what we see as a decline. And we do see the corresponding increase in breast cancer. And we know that the epidemiological factors are exactly contra with breast cancer, because the later age at marriage, fewer children, fewer lactation, all of these contribute more to the breast cancer. So this is possibly the reason. That's okay. Now, what is good is that when it is already on the declining time is exactly the time to strike with our to eliminate cervical cancer. We can get a quicker decline when it's already on the declining trend. And to have the comfort that we are reaching elimination level of 4 per 100,000 is not good enough, because many countries have shown a U and it goes right back up because of various lifestyle factors and so many others. So definitely it's good news that it's declining. It's the right time to act for elimination, and complacency and believing that it cannot go up again is not desirable.
Yes, absolutely. So this has to be maintained to actually keep it low and not stop screening or vaccination. So, Dr. Nija, we now have the Indian-made vaccine, and now we have the Indian HPV tests. So, do you think we are on the right track for cervical cancer elimination? Do you see any bottlenecks, any challenges at this stage?
I be poised on really on the verge of taking off, so to speak. But yes, vaccine accessibility is still a problem. It's a paradoxical situation that globally there are more people wanting the vaccine than is vaccine available. So now more and more vaccines are being produced. And we hope that in India also it will be scaled up to the extent that we will have enough vaccine very soon for all the women and all the girls. And so that's one aspect of it. And we have a situation where we have the HPV tests, which have now gone through our DBT project. They have gone through the licensing, the validation, and they are available, but we need to scale up to that level. And as I said, the implementation. And why we emphasize on the Indian ones is basically that we expect that their costs will be more affordable, and when they go through a process as is the usual one for procurement, they will be found to be something that can be easily incorporated into our program.
Right. So right now we have the super specialty courses since the past 10 years in gynae-oncology. So do you think they are necessary for treatment of pre-cancer and cancer? So do you think only the super specialists should be the ones who are managing them?
No, I definitely do not believe that only super specialists can manage them, because I think we have more courses now. We have more being turned out. That's great news. But for a country our size, that can never be the case. And there was a time when in every medical college, the professors were doing radical hysterectomies. At least the Verdime was a given. And somewhere along the way, that has gone. So I think it's important, and that's again something which the Fogsi Oncology Committee, as well as AGOY, our Association of Gynae Oncologists, really can help with, is to do some hand holding and training of people who are interested in the medical colleges to help them to do radical hysterectomies. The more and more we have the implementation of the national screening program, more and more these silent cancers are going to come forward, and we do need them to be treated in all the states, in all settings which are closer to home and not having to travel too far. Because it's terrible for the families. They fall out on families when they have to travel, the financial toxicity, losing their jobs, emotional issues. So we do need to make sure that every medical college is geared up, whether a super specialist or not a super specialist, when it comes to radical hysterectomies. Pelvic exentrations and that level of things, I can understand that those should be more in the realm of the super specialists, and that is not that many cases, and that can be figured out. But for the mainstay of it as radical hysterectomies, certainly super specialists, of course, should do it. But even in medical colleges, somebody with a special interest in gynae-oncology should be identified who can do it. But for precancers, it is our average Foxian who has to be trained. Every Foxian, ghar Foxian, har shahar Foxian, whichever way you look at it, they must all be confident to be able to identify precancer and to treat it. And why only the Foxians? We should actually be enabling even our family physicians, even MBBS doctors, to be trained for simple procedures like thermal ablation. In fact, even nurses are doing this so well in Africa, in Thailand. It's another matter that we are really, really short of nurses. We don't have enough nurses to fill the nursing cadres. And so we don't know about making them move into other tasks like screening. But I think somewhere we have to reconcile this gap, and we have to make it so that every woman gets the treatment she needs and deserves to be able to prevent this cancer.
Yes. So how do you think, integrating with the nursing council, the medical, the NMC can ensure that this actually happens in the medical colleges?
Yeah, I think this dialogue is definitely required. And, even
Hmm.
I would say, even our ANM, some of the ANMs who have worked with us for years are so good. I have tried showing a case to an ANM who has worked in this project versus a JR and asking them, what is this? And it's the ANM who answers first and says, this is cervical cancer, even before the JR has wrapped her head around it. So, it's all about training eventually. There's no rocket science really involved in doing simple procedures like visual inspection and identifying lesions. Making a simple checklist on eligibility is already there in our national program guidelines, so we can very well train people at every level. And I think this is a dialogue which we should consider initiating, to see whether we can have interest from some nursing professionals who may be keen not to pursue active nursing but happy to do this kind of work. I think options should be offered to all people everywhere.
Right. So how do you think, Foxians can help in cervical cancer elimination? They are the ones who are the ladies approach if they have any symptoms, but how can they help in the initial, in the prevention, the screening? How can they help in promoting this in the populations that they serve?
Here I must appreciate the efforts of all our presidents whom I have worked with as a chairperson in the Gynae Oncology Committee of Fogsi, or as vice president in Fogsi, and now we have Dr. Sunita currently. But each one of them has taken an active interest in cervical cancer prevention. And we've had a Foxy Figo project in the Northeast. We've had those uh, train going and doing screening programs when Dr. Bhagyalakshmi has done. Dr. Alpesh has been keenly involved. Dr. Pai has been involved. Dr. Jaydeep, Dr. Sunita, everyone has been keenly encouraging these cervical cancer prevention programs. And that speaks volumes for when it comes from the top, from the leadership, that there is a positive interest in this in the federation already. Now comes the active role of the Foxian. So, it's not as glamorous as some disciplines of gynae. It's not got that kind of a wow feeling, but trust me, the feeling that you get that you can actually prevent a cancer is a very, very empowering feeling. And I think it's a good thing for all our gynecologists so I think if we can have a day declared, and I think it has been discussed already, that we should do something like that, that may remind gynecologists more often. Have something simple in your clinic that will alert people that this is an option. Offer maybe self-sampling if it's a very busy clinic and you cannot spare the time to do the screening yourself. Learn how to do a simple visual inspection, colposcopy, learn how to do a thermal ablation, very, very simple. I think that's a great tool which every gynecologist should possess. And even learn how to do a leap, which is not difficult for people who can learn to do a TLH and who can learn to do endometriosis surgery. What is learning a leap? I think it's a bit of a mental block. So I think maybe Foxians should consider it mandatory that they must do cervical screening as a part of their responsibility. I call it CSR, cervical screening responsibility. So have a thing of, have I informed every woman who came that she should be screened? And I know there are many gynecologists who are doing it very regularly. Have I offered vaccination to everyone who is eligible? I remember Dr. Nozer telling me that every one of his nieces who had become eligible would receive this as a gift from him. So maybe, we begin at home, we tell everybody, we get convinced about it ourselves, and we make sure that the message goes out loud and clear that yes. And this is something, when every doctor is asking the patient, have you been screened, have you been vaccinated, it will make them realize that this is something of importance. Everywhere I go, people ask me this. So it is something I should do. So I think Foxians can really be the ones to make a difference, because at the end of the day, the patient trusts the gynecologist a lot. And it matters what the gynecologist says.
Yeah, I think, yes, they have a huge role to play in the lives of the women they treat in generations, for generations to come, not just that generation. Yeah, so Dr. Nija, now you are on an international platform now. You are a consultant to IR. So how do you feel, and how did you actually feel when you got this award from IARC, and when you got actually recognized by the government, uh, when you went for the Quad Summit, and then how when you got the Padma Shri? How did you, what were your emotions, and how did you feel?
Yes, I must say those were very, very awesome moments. I mean, to be asked to go for the Quad Summit was also something really that touched me deeply, to be considered worthy of this moment, and to be able to meet PM Modi for the first time, actually, and of course, other eminent. The presidents and prime ministers of the other Quad countries, as well as the delegations from those countries, and have those interactions. It was really, really awesome. And I hope that we can have some follow up for that. But the getting recognized for the Padma Shri was no less of a humbling moment, as well as, I mean, it was initially a little bit incredulous that this has happened, actually. And at the same time, I think it was something which was very you felt a sense of responsibility, that somebody has recognized you for cervical cancer, which is, now what we have called, it's called the People's Padma. People can nominate you and select you for the award. So, to realize that this is carrying importance in the minds of people, it's very encouraging, as well as a deep sense of responsibility that the goal has not been reached yet. We've only been on the path so far. So the need to be on that path further on. One thing I really appreciated was the opportunity to meet people from different walks of life, and the realization that you can now reach out to them and talk to them for stepping into areas that you were previously unfamiliar with. So I think all in all, it's been a very humbling experience, a very gratifying moment, and the need to go on. You feel enthused to go on, and I have only to thank all the people who have worked in this field with me, alongside me, in parallel, in tandem, whichever way we have all worked. A very like-minded community with a single goal, and I hope that we can continue to do that and reach the final goal, which is cervical cancer elimination and cancer mukt Bharat and all of that.
Yes, thank you. And what is your message, for the all the Foxians watching, and the younger generation, actually?
So I definitely hope that there will be people who will be enthused in the younger generation, who will want to take this on as a mission, not just on the side, like I said, of doing a few screenings every day, but there is really still, we know a lot. We know a lot. We have enough information to act on. But I'm sure there is a lot more that we can do to refine it in the future, to find better triage tools, to find better implementation strategies, and to make it, and even with vaccination, there will be further and further developments, better vaccines, younger ages of vaccination, coordinating it with childhood vaccines, and not having to worry about this platform of school, adolescent, and all that. So there is so much that is there to be done still in the way of research as well. And I hope that there will be some who will make it their primary goal. But in all situations, I hope that they will take back the message to their own communities, to their own neighborhoods, and take it on personally, to see that nobody is left unscreened, nobody is left unvaccinated. And certainly, where there are people can afford to take it themselves, we would like them to vaccinate the boys too. The boys will gain from the vaccinations for themselves also, not just for the cervical cancer goal. So we would like to encourage everybody to move forward in this field, to take advantage of the information we have from science, and use the technologies to make the world a better place.
Yes, thank you so much. Thank you for sharing, all the valuable insights and the valuable advice, the guidance. You've been a mentor for a lot of us, and I hope you continue to mentor all of us in this journey of cervical cancer elimination. So hopefully, in the next few years, we should be getting towards having that figure of less than 4 per 1 lakh women. Thank you so much, Dr. Nisha, for joining in. And I hope you have a good day today and a good time with your family.
Thank you. Thank you so much.
Thank you, support team. Thank you.